Okay. So I have the unenviable task of summarizing a very thorough National Academy Consensus Committee report in less than 20 minutes. Biomarker tests for molecularly targeted therapies. And I'd like to acknowledge a lot of help and input on this talk from Deborah Leonard. So these are my disclosures. Study sponsors of the talk, of the committee that I was on. And these are the committee members, hardworking group. I was very happy to participate with Jane. She was a terrific participant in this, and Hal Moses chaired it and did a great job. So the charge of this committee was to examine policy issues. And I should just say that the major theme here is that this committee was really taking a very high-level view of a very fragmented and complex ecosystem involving patients, healthcare providers, third-party payers, diagnostics, and providers and patients, and trying to bring this all into view and to see how something could be worked on, bringing all these groups together to further the cause of understanding and providing better markers and therapies. We wanted to review opportunities for and challenges to the use of these tests and formulate some recommendations to accelerate progress. We focused on a couple of areas: regulation, reimbursement, and clinical practice. But those were areas of focus, but not to the exclusion of many other areas. And these are the key report themes: that we really need to have accurate, reliable, and clinically useful biomarker tests for molecular targeted therapies; that there's a lot of variability in the evidence that's used to inform regulatory, reimbursement, and treatment decisions; and that reimbursement will continue to evolve as evidence is generated and new information becomes available. Regulation, coverage, reimbursement, and practice guidelines will all evolve, and that data sharing is essential, and that we need to think about alternatives to the formal randomized controlled trial as the only way to test markers and therapies, and that rapid learning system as a way of collecting and analyzing data information enables a continuous learning from both research and clinical practice. This is a overview picture that really emphasizes the three areas that we focused on in the committee. One was to develop a more supportive policy environment, to support data infrastructure that allows us to interrogate and analyze the data, and processes that will improve patient care, including equitable access to these tests, improved specimen handling and documentation standards, and clinical practice guidelines. So in terms of supportive policy environment, our first recommendation, the goal was to establish common evidentiary standards of clinical utility using evidence generated both within and outside the context of clinical trials across all stakeholders. And that this was something that we thought could be done through the facilitation from the Secretary of Health and Human Services. Second recommendation was to establish a more coordinated and transparent federal process for regulatory and reimbursement decisions for biomarker tests, and that we need to have a more integrated federal review process that includes a pathway for coordinated regulatory coverage and reimbursement decisions for in vitro diagnostics, for laboratory-developed tests, for next-generation sequencing biomarker tests, etc. Our third recommendation was to enhance communication to patients and providers about the performance characteristics and evidence for use of specific biomarker tests, so we have both a better informed provider group and a better informed patient group. And that we need much more patient and provider friendly standardized labels for these tests, that most physicians and many patients don't understand what these biomarker tests, particularly genetic tests, are about. Our fourth recommendation was to update and strengthen the oversight and accreditation of laboratories providing biomarker tests for molecularly targeted therapies. This is a whole area in of itself, but we do need more up-to-date laboratory accreditation standards. This could be done through CLIA or in collaboration with other accreditation organizations, but we need to have a clearer and more up-to-date and, frankly, more sophisticated accreditation standards. Our fifth recommendation was to ensure ongoing assessment of the clinical utility of biomarker tests and that we need to have ongoing collection of data within a rapid learning system, and that in addition, we need to have granting mechanisms that'll support this sort of assessment of clinical utility. It's actually very, very difficult to find the support that's needed to actually gather and collect and analyze this data. There are not very many sources of support for what I think everyone recognizes is a critical function. We can all talk about analytic and validity and clinical validity of these tests, but until we actually show clinical utility, it's not worth talking about. So we view this as an idea that there should be some sort of reimbursement policy mechanism to support the ongoing assessment of biomarker tests, from the investigational experimental on the left through to adequate evidence for initial clinical utility, and then continued coverage with the collection of data to assess clinical utility as the strength of evidence rises or falls, in which case it's no longer covered. The second group the second area that we focused on was supporting data infrastructure, that the electronic health records and related biomedical informatics tools can be much better used, and also there can be much more interoperable and communication between these tools, that we need to be able to capture this information. Currently, I think it's fair to say that most electronic medical records do a very, very good job of census and billing, and don't really do much in support of clinical research. That's really not what they were designed to do. And that we need to be able to also have the electronic medical records facilitate point-of-care decision support for biomarker test ordering, reporting, and shared clinical decision-making, as some of these markers and some of their application can be quite complex and difficult to implement, and that providers and provider education groups, professional groups, really need to work on developing these point-of-care decision support tools within electronic medical records. And that, as I said, we need to have healthcare institutions and physician practices use electronic medical records that do facilitate the point of care support, and also that we could build in CME, CEU, or other sorts of maintenance of certification could be achieved through interaction with these point of care decision support materials. In other words, much more emphasis on maintenance of certification that doesn't come from some kind of artificial testing, but instead comes right out of the day-to-day practice. Our seventh recommendation was to develop and maintain a sustainable national database for biomarker tests for molecularly targeted therapies, and that this national repository, there's many, many registries, many, many repositories, and I know the Precision Medicine Initiative is certainly looking at this. They don't all, of the many repositories that exist now, some are closed, some are proprietary, they don't talk to each other. There's certainly not a federation of these, and so that there's a lot of information that's siloed and not available. The third was processes to improve patient care. Our eighth recommendation was to promote equity and access to biomarker tests for molecular targeted therapies, and we need to have funding to identify and overcome. I think the identification has been something that people have been doing for years, and I think we know at least what some or even most of the barriers are to promote equity and access, but we don't necessarily have the tools to overcome them in a large-scale manner. Another recommendation for this particular goal was to support some demonstration projects to enable and assess the effectiveness of collaboration between community health providers and larger healthcare centers. This is going on, but it could be done more expansively, and also reaching out to other groups that are not represented in the clinical trial and clinical study community. Ninth recommendation was to enhance specimen handling and documentation to ensure patient safety and the accuracy of biomarker tests. I think people were looking specifically at this issue of particularly tumor testing and somatic genetic testing. What really are the requirements for handling those specimens, for making sure that patients are not exposed to inappropriate excessive biopsies, and unnecessary repeat specimen collections because the initial specimen was inadequate, and that we need to really focus on making sure that we have professional guidelines for this. And then the 10th goal was to improve the process for developing and updating clinical practice guidelines for effective use of biomarker tests, and this needs to be an interdisciplinary collaboration, develop integrated guidelines so that we can have the urologists and the medical oncologists and the geneticists and the nurses speaking to each other about what is the appropriate use of biomarker tests in, let's say, an area like prostate cancer. So taking a step back, what we viewed across the bottom are the three areas that I talked about, which is policy environment, data infrastructure, and patient care processes. And then above those three are the recommendations and how they sit. But I think this is a complicated picture, but I recommend that you look at the National Academy of Medicine report that Hal Moses's committee reported on. But I think the key element here is the arrow on the right, which is rapid learning from research and clinical practice, then gets reincorporated into the process so that we have a process of, perhaps it might be asymptotic, but a process of continual improvement as we learn, implement, learn more, implement more. And with that, I'm going to stop. This is where we download the report. You can view more resources. That's the picture of the test. I thank you very much for the opportunity to just review this with you this morning. We'll do on time, okay? Good. Any questions? I know that was breathtakingly fast. Jeff.
Jeff Ginsburg from Duke University. Thanks, Robert. Could you comment particularly on the rapid learning model? What are the financial incentives that will incentivize health system leaders to actually build the infrastructure to create that? So it seems like the incentives have to be aligned to make that happen. And right now, we're not in an environment that is conducive to that.
Yeah, that's obviously a key point. You know, you always need to follow the money. So what I viewed is a couple things. First of all, it's quite clear that healthcare is consuming a huge fraction of the financial power of this country, and it doesn't seem to be diminishing. And so that investments now that could, in the long term, markedly reduce healthcare costs, I think is one incentive that would involve government, third-party payers, although I know they hate even the idea that they're going to help support some sort of research. I've often heard, I know I see Nan Aronson in the audience, I've often heard her speak about this topic, that sort of it's not their problem. It's they're happy to support things that are clinically proven, but it's not their job to support research. And CMS, good, I'm glad that I inspired her to get up and comment. And I also think the healthcare systems, although of course they have very narrow profit margins and don't have a lot of extra income to be able to expend on this. But I think that as a entire ecosystem, instead of having it fragmented with each person sort of saying, well, it's sort of, I can't do that, they have to do it. I think if we all got together and contributed to it, the financial incentive would be, in the long term, would be to save money and improve outcomes. And I know that sounds a little bit like, or maybe even more than a little bit like, mom and apple pie and waving the flag. So maybe the bottom line is that I think we need, I personally think we need to rethink the entire way that that this sort of research is not only implemented but also supported. But you know, who'd have thought healthcare was so complicated? Nan.
Thank you. Dr. Califf has kindly yielded the floor to me, and I want to clarify what I have been saying all these years. It is not that payers hate being involved in research. In fact, I was part of the leadership for the support for the breast cancer trials back in the 90s. And I was pregnant with my son, who is now too old to be on my health insurance plan. And I look at how coverage with evidence development has been absorbed. And what I am actually trying to convey are both opportunities and barriers. One of the problems is that coverage with evidence development has not been used to support research. It's been used to support coverage. And it's been used historically to find the simplest path to coverage and the simplest, maybe I should say simple-mindedness, sort of data collection. That would need to be rectified. And while I agree with you, we need to have a very broad use of look at what the role of trials and observational data and adaptive trials and how they all fit together. There has been a real fear of trials, which is a fear we did not have with the bone marrow transplant trials. And in fact, had we had that fear, women would be still subjected to that today, unnecessarily, with adverse consequences that I don't think have ever been fully documented. So I want to put on the table here that one barrier is figuring out how to get good research into the coverage structure. And another barrier is the coverage structure doesn't necessarily adapt to this too well. It's problematic from a contractual point of view. And at times there's been considerable support from our plans. At other times there's been reluctance to go forward with this. I think the recession in 2007 set us back quite a bit. And I think another piece of this is got to stop thinking about insurance as the deep pockets that can support everything. Because really what insurance is, it's the reallocation of workers' wages, of workers' salaries to healthcare benefits. And we're also entering an era where access to these is really under fire, and we don't really know where we're going to end up. So with that, I thank Dr. Califf, and I thank you for giving me the opportunity to clarify what I've actually been saying for 30 years.
Wonderful. Thank you.
You should run for office.
Yeah.
That was a great talk about what I thought was a brilliant report. But I do want to refocus you back and provoke you a little bit to respond to what I think Jeff was asking, which is related a bit to, I think, what Naomi said. I'll just point out that just making a list of tests was considered in the last administration to be too onerous a task to confront test developers with. So sort of at first base, we're not getting there. If I remember what Jeff asked, it was about the CEOs of integrated health systems. And I think Naomi's correctly pointing out that the money is going into a system that's spending a lot of money. And the question of how it's spent is partly coverage issues, but it's partly the internal workings of places like yours and mine, where there's such a gap between what the rhetoric that you just displayed, which is tremendous. And, you know, anyone who didn't buy onto that, I would have to wonder about them. And then the reality of what's happening on the ground, which is quite different. So how do we, what are your thoughts about how to begin to really close that gap?
So those are really critical questions. I guess that one comment I would make is that you know, I think healthcare systems such as the one where I'm volunteer faculty now, or you work at Duke, are only a fraction of the total engine of healthcare cost and healthcare delivery. There's a huge amount that's happening completely outside any of the academic medical centers, and I would argue is essentially outside any kind of review or data collection. With the exception probably of what the third-party payers know about what they're covering, we have very little information on outcomes as the way this healthcare system is working. So, you know, I don't have a magic solution to what you're describing, except to say that we can do better than we're doing now. And that what are the obstacles? That some of the obstacles I think that one can identify are that the system is very, very fragmented. And so that improving the ability to collect data is critically important. The other is, and I think I'd like to echo a little bit of what Jane talked about. I've been really impressed over the last couple of years where I've switched from academia over to working at a diagnostic company. The extent to which patient empowerment is underrated, and the role of patients in driving the collection of information voluntarily, with obviously with their consent. But this switch that I think is happening in society now, and it's not universal by any means, it's very fragmented, but there is now, I think, a developing sea change. It's beginning in the rare disease community, but I think it's expanding into the other community of patients switching from being passive receivers of medical care from a very well-meaning, but, and I'm going to say this in all humility, paternalistic medical care system to one in which the patients are much more active, much more interested in pushing the boundary, and are less accepting of delays and obstacles. They really want to participate. Now, Naomi raised the point that, yes, there may be a lot of patient groups who might be pushing for something which turns out to be not only useless, but the wrong thing, a bad thing. And so obviously, we're not talking about cutting the research community out of this effort. But I'm encouraged by the growing interest of patient groups to drive, to participate in, and to really further this role of trying to get better clinical trial information done and get the clinical trials done and better information. How to pay for it? I don't think there's any one group that's going to be able to afford this. So I think it has to be a contribution across many areas of society. So, for example, in my company, our philosophy is to drive the price of genetic testing down so low that one of the groups that contributes to developing data is actually the patients themselves who are able to afford genetic testing. It's not out of the realm of possibility for the vast majority of people in this country. Certainly not all. And that, of course, underscores the disparity issue that still needs to be kept in mind and kept front and center. So I think patients can contribute. They contribute through their healthcare dollars that they are contributing from work. I think the healthcare systems need to take a really good, hard look at where they're spending their money and how they're spending their money in order to do a better job of turning the healthcare system into a learning laboratory. I don't think there are very many healthcare systems that see themselves that way, particularly not the ones that are outside of academic medical centers. And I think the government has a role to play in contributing to this as well. So I don't think there's any one group that can pay for this, but I think we can all contribute to it and improve the entire ecosystem. And Rob, I don't know if that's even comes close to chipping away at the question you asked, but it's about the best I can do. Yeah. 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 And as I said, I think the academic medical centers are really a small component of what's really going on out in the country. Yeah. Yeah.
Deborah Leonard for University of Vermont. How much could you comment on whether you think the changing payment models, which are actually raging in Vermont, I don't know, they're not moving forward as fast in other areas of the country, but moving to a global payment model for population health management, how much do you think that will transition care to more integrated, coordinated, and the possibility at least of creating learning health systems?
I don't know that these different payment systems will intrinsically sort of themselves result in that. I think that needs to be part of the plan if you're going to institute such a change in the payment system, to say, and as part of this, we need to collect additional data to make sure that what we're doing actually is effective. And so I don't think it's just going to flow naturally from that. I don't think it's going to make that much difference unless there's a change in attitude about how we learn about what we do, and therefore improve what we do.
Right. But as you move from fee for service to global payment, you don't survive unless you do that.
Well, I mean, I hate to be cynical about this, but I think it's possible to survive by just simply saying no and cutting what is offered without making any contribution to expanding our education and knowledge. I should say our knowledge about what's going on. So I think there are ways of surviving that are not necessarily contributing to our improvement in our knowledge. Any other? That's good. Well, I'm glad that I was able to inspire some questions and comments and maybe even a little controversy. Thanks.